Neurology in Primary Care, developed by Templeton Institute for Neurology. Templeton Institute for Neurology is a comprehensive neurology practice dedicated to the diagnosis and treatment of neurologic disease. We are located in San Luis Obispo, with a satellite office in North County. Our Neurology Second Opinion Clinic in San Francisco is held once a month. We apply the same excellent standards we use assessing patients who see us for an initial consult to the patients who see us for a second or third opinion. This is why our success rate is more than 38% in changing diagnosis or treatment when we do a neurology second opinion. We do not promise miracles, but we frequently change quality of life. This review, even though it's comprehensive, should not be used as the sole source for physicians when they are making decisions regarding treatment of their patients. The Dilemma of Subclinical Hypothyroidism in Primary Care Practice, Part 2. In Part 1, we address the following three questions. 1. What is subclinical hypothyroidism? 2. Conditions which could mimic subclinical hypothyroidism. 3. What do I do? In Part 2 today, we are going to address the following questions. 1. Neurologic manifestations of overt hypothyroidism. 2. Is my patient neurologic symptom due to subclinical hypothyroidism? 3. What we do at Templeton Institute for Neurology. We start with refreshing your minds of the definition of subclinical hypothyroidism. Subclinical hypothyroidism is defined as a normal T4 in the presence of an elevated TSH. The upper range of normal for TSH is age-dependent and goes up with age. Subclinical hypothyroidism may occur in the presence or absence of mild symptoms of hypothyroidism. Most patients will have serum TSH levels 10 mUl and are asymptomatic. We start with addressing the first issue, a subject most of you are very familiar with: neurologic manifestations in overt hypothyroidism. Cognitive impairment in hypothyroidism. Myxedema madness is the extreme of these conditions, with psychosis, disorientation, delirium and psychosis. But this is a very rare entity nowadays, considering that the threshold for ordering TSH screening is very low for many physicians in clinical practice. The more common cognitive impairment presentations with overt hypothyroidism are slow mentation, poor concentration, difficulty with short-term memory, and depression. Many of these cognitive impairments will improve with treating hypothyroidism. It is important to understand when judging recovery of cognitive deficits with thyroid therapy that these cognitive issues are accompanied by other hypothyroid symptoms and signs like constipation, fatigue, cold intolerance, dry skin, bradycardia, and other findings common in hypothyroidism. This rule of reversing cognitive deficits with thyroid replacement in patients with overt hypothyroidism does not work very well when dealing with subclinical hypothyroidism and cognitive impairment. A study published in the Gynecological Society of America in 1985, supported by NIH funding, evaluated 200 patients over age 60 with a diagnosis of dementia. 70% of those dementia patients had Alzheimer's type dementia. On the other hand, 31% had more than one illness contributing to the dementia state, with overlap between the two groups. The most common of these treatable illnesses were drug toxicity, hypothyroidism, and other metabolic diseases. After treating all the possible causes, 55 patients, that is 27.5%, improved, while 28 patients, that is 14%, did not. Only 2 patients recovered to normal. This study emphasizes the importance of recognizing and treating the multiple illnesses that contribute to dementia in elderly adults. You may have doubts about the association between subclinical hypothyroidism and cognitive impairment. This becomes even more of an issue if you subscribe to a more relaxed approach to treating subclinical hypothyroidism. But there is some studies supporting the association between subclinical hypothyroidism and cognitive impairment, even though the improvement with thyroid replacement is not satisfactory as we would like it to be. A study from the Department of Psychiatry, School of Medicine, University of Pittsburgh, published in 1996, has shown that the odds were 3.8 of finding elevated TSH is a definite or possible dementia patients they have studied. A total of 194 patients, all 65 years or older. How do we approach treating cognitive impairment in association with subclinical hypothyroidism at Templeton Institute for Neurology? We are going to discuss that later in this podcast. But it is important to mention that at Templeton Institute for Neurology, we recognize two sets of cognitive impairment. 1. Those deficits which are measurable by standardized testing like mini mental status exam and other psychoneurologic testing batteries. 2. Objective cognitive impairment. These are the complaints of the patient not feeling as sharp as used to, feeling foggy, or other vague cognitive impairments the patient complains of, while they still perform well on subjective quantitative testing. These patients are frequently the ones that pressure the boundaries of evidence-based medicine, and to help them, we as physicians have to tap into the art of medicine. Please do not press the pause button yet. There is more to come after this short break. I welcome you back, those of you who are still listening. Peripheral neuropathy and subclinical hypothyroidism. We intended this podcast for primary care physicians, so we are going to refrain from discussing the pathology basis for neuropathy in hypothyroidism. But it is a well-established fact that overt hypothyroidism will lead to neuropathy. This neuropathy is frequently a sensory neuropathy that could affect the larger myelinated fibers or the smaller unmyelinated fibers. The severity of the neuropathy is believed to be related to the duration of the hypothyroidism rather than to the degree of the hypothyroidism. In other words, the longer the hypothyroidism, the more advanced the polyneuropathy. Now, before we go any further, I would like to address a very common misconception about nerve conduction studies and neuropathy. Well, nerve conduction studies can only detect abnormalities in the larger sensory myelinated fibers, but cannot help in case of unmyelinated fibers. So it is frequent that we hear the comment from patients saying, "My nerve conduction studies were normal. I was told that I do not have neuropathy." The correct statement should be when talking to your patients, your nerve conduction studies are normal, so you do not have evidence of large fiber myelinated neuropathy. Small fiber neuropathy is established by meticulous clinical neurologic exam and can be confirmed by biopsy. Biopsy, for the sole purpose of confirming the diagnosis of small fiber polyneuropathy detected by clinical neurologic exam, is very rarely needed in clinical practice. Now, back again to our most challenging patient, somebody with subclinical hypothyroidism and evidence of polyneuropathy on clinical exam. What do we do at Templeton Institute for Neurology? We will again answer this question later. The most important step, in our opinion, is to have an extensive workup looking for an etiology for the patient neuropathy. Our approach to sensory polyneuropathy at Templeton Institute for Neurology is somewhat different from the typical mainstream. We observe early polyneuropathy in the same glasses that you observe fever. Early neuropathy in otherwise healthy person is more like a sensor for a mild ongoing systemic illness, very much like a low-grade fever of unknown origin. We are not satisfied with checking hemoglobin A1C and TSH. We do an extensive workup before we call the neuropathy idiopathic neuropathy. What do we do at Templeton Institute for Neurology? We subscribe to the concept that practicing medicine is an art. We also know very well that physicians practice according to the most convincing literature they have read and shy away from the weak studies. With that in mind, when it comes to subclinical hypothyroidism and neurologic conditions, we like to only recommend to the treating physician what we feel is the most appropriate approach, combining the state of the studies we have reviewed, our own experience with subclinical hypothyroidism, all blended with the art of practicing medicine. As newer and better studies are published, our treatment roadmap will also change and evolve. As of the time of recording this podcast, Templeton Institute for Neurology roadmap for approaching treatment of subclinical hypothyroidism follows these principles. 1. The patient has measurable cognitive impairment by standardized testing. Treat with thyroxine indefinitely. 2. The patient has objective cognitive impairment not detected by standardized testing in the absence of depression, sleep apnea, periodic limb movement disorder, complaints of tingling and numbness in the feet, and polyneuropathy. Treat until TSH is normal for 3 to 6 months. If no improvement, consider the risk of osteoporosis and arrhythmia. Then make your decision about continuing therapy. 3. The patient has lower extremities polyneuropathy without a clear etiology after extensive workup. Treat and maintain TSH in therapeutic range for life. 4. The patient has lower extremities, numbness and tingling without polyneuropathy in the absence of plantar fasciitis, motor neuroma, tarsal tunnel syndrome, and other foot conditions which could cause numbness and tingling. Treat with thyroxine for 12 months. If any objective improvement is realized with the hormonal replacement, then continue thyroxine with TSH maintained in the normal range indefinitely. If no improvement has been realized in 1 year, consider the risk for osteoporosis and arrhythmia, then make your decision about continuing therapy. 5. The patient has cognitive impairment, subjective or objective, and polyneuropathy without any clear etiology after extensive workup. Treat with thyroxine for life, even if improvement is not realized. This concludes our episode for today. Thank you for listening to this episode of Neurology in Primary Care by Templeton Institute for Neurology. For comments, or if you would like to be a contributing author to our podcast, please email us at templetonneurology@gmail.com. This episode was made possible by the generous contribution of Templeton Institute for Neurology. Templeton Institute for Neurology is a comprehensive neurology practice dedicated to the diagnosis and treatment of neurologic disease. We are located in San Luis Obispo, with a satellite office in North County. Our Neurology Second Opinion Clinic in San Francisco is held once a month. We apply the same excellent standards we use to assess patients who see us for an initial consult to the patients who see us for a second or third opinion. This is why our success rate is more than 38% changing diagnosis or treatment when we do a neurology second opinion. We do not promise miracles, but we frequently change quality of life. This review, even though it's comprehensive, should not be used as the sole source for physicians when they are making decisions regarding treatment of their patients.